Thanks, John. Delighted to be here and delighted to be doing this lecture, the Bobby Shields lecture. I knew him briefly in his time really as president, and he was an interesting man. And it is appropriate to be standing here on the banks of the Clyde because he was born just downriver on the other side in Paisley, the son of an electrical engineer. As John said, he went to the local university where he fell under the thrall, that's not the right word, but of Sir Charles Illingworth, who was that doyen that placed so many professors of surgery in the UK for so many years. He was very much an Illingworth boy. He was his houseman in 1953. And then he went off and did his national service with the Argyll and Sutherland Highlanders. And that, I think, when you look at the way Bobby Shields was and how he had his approach to things, he was absolutely meticulous in his preparation for meetings and for lectures. And he wrote a wonderful article on how to prepare and deliver a lecture that was published in the BMJ. And he called it his staff work. And he had an undoubtedly military bearing or military attitude in that background work and in the way that he behaved and ran things. And you know, his obituary talked about a quiet man of cast iron integrity, and he was a leader. He was just slightly short of tyrannical, but then, you know, I was going to say he was a short man. He was the right man to be a professor, the right height to be a professor of surgery. He did his research at the Mayo, and he won the Moynihan Medal of the Society, came back to be lecturer in Glasgow, senior lecturer in Cardiff, and then the chair at Liverpool for 28 years, during which time he was the dean of the faculty. He was vice chair of Merseyside Health Authority, and that's what he was knighted for in 1990, was his services to Merseyside Health. And he had many other accolades over the years. And he was president, and he was a good president, a strong president of the Edinburgh College in the mid-1990s. And from that time, he wrote a good report that the Scottish office at the time had asked for on commissioning better health. And he said in it, he recommended that, and at the bottom bit there, with health boards focusing on clinical outcomes and the monitoring of clinical practice using data from clinical audit. And he was a supporter of what was being done then in surgical audit. And that's really what I've taken as my subject for today. I've no conflicts of interest to declare there, and I acknowledge happily the help of many folk. You know our health service, and it has an old reputation that Dr. Finley's casebook had. We have some quaint surgical techniques north of the border. And mortality was a subject for audit, one of the earliest subjects for audit. And that's what I'm going to talk about, the Scottish Audit of Surgical Mortality, and I've put the crests of both the Scottish colleges there because it is a daughter, SASM is a daughter of both the Glasgow and Edinburgh colleges. You could subtitle this talk a shared learning experience, although the truth of the matter is, I think, more like that. The aim of SASM, very clear, to improve the care of surgical patients in NHS Scotland through learning the lessons shown from high-quality comprehensive audit, and to measure that improvement and demonstrate effectiveness, and that's where the rub lies. That's the broad methodology, critical event analysis by peer review, and that's the way that it's been done. And then return that, and again, that's a huge issue, and make the data available at national and at health board level. As I say, surgical audit, and particularly surgical audit of death, goes back a long way. And the leaders north of the border were undoubtedly the Lothian surgical audit, which started way back in 1946, but was brought very much into the present day by Steve Nixon in Edinburgh, and he put a huge amount of work into it. Glasgow came on board, and then SASM started in 1994, and there have been specialist topics ever since, and the hip fracture one was one that I was involved with in times past. So SASM has been going since 1994, all surgical specialties with the exception of cardiothoracic and obstetric. So even all of them are involved. The surgical audit audits inpatient deaths under the care of a surgeon, whether they've had an operation or not, and up to 30 days. So we don't capture those who subsequently die at home. We don't capture those whose care is transferred to another specialty. 51 hospitals, 2,500 consultant surgeons, anaesthetists, intensivists, interventional radiologists, they're all involved. So even the orthopedic surgeons are in there, even the plastic surgeons are in there, and even our anaesthetic colleagues are in there. So it's a broad church. About 3,000 deaths a year. The peer review process and the intention is annual and individual case reports. But thing is, death caused by individual error is extremely rare, and that's been one of the factors over the past few years. And I know you had your session yesterday on the Francis report, and there was Zabrowski's decision to publish the mortality raise. And we've been through that in 2006 as the result of a freedom of information request from 2 journalists. And I think we should be open about this. Yes, there are qualifications, and we'll come to that in a minute. But if there's any scent of us trying to cover up, then we're doomed. And the bottom line there is what we need to capture is to learn from that audit. That was Martin Porter from the BOA talking at the Edinburgh President's meeting last month on outcomes, which was a great day, and it was very interesting. And yes, we have to have buy-in. This, if it's to happen, must be backed by the profession. If it becomes antagonistic, we're in real trouble. Yes, we have to stress the approach of the team. And when we did the hip fracture audit, we never took it down to individual surgeon level because it was meaningless, because it was such a team event. So you took it to hospital level. The presentation is hugely important. It has to be real and it has to be understandable by the public. And it does prompt the risk that we split away and people just don't want to take part, that they start doing risk-averse behavior. And yes, there is an effect on training. And there may be an unjust reputation because there's plenty of examples around the country where somebody is in the bottom quartile one year and then the top quartile the next year. So, snapshot analysis that unfortunately make the headlines are not helpful. In NHS Scotland, we've got the Scottish Patient Safety Programme, and that has had a major effect. And we look at mortality over recent years, and there has been a substantial decline from 2007 to 2012 in those 5 years, 12.5% reduction, and that represents 8,500 fewer than expected deaths. And when we look at the rate, you see, there was the rate going along from 2002 to 2010 at a 1.4% annual reduction, and then latterly a 4.2% annual reduction. And that's where the patient safety program came in. And I'm pleased to see George Youngson in the audience, because George takes a lot of credit for what has been done north of the border in trying to implement these things. Surgical mortality within that has shown the most striking reduction, and so has ICU mortality. So all of that makes an audit based on mortality slightly dubious and difficult. And this isn't limited to us, and that's John Birkmeyer again from the same meeting showing exactly the same thing across the pond with reduction in mortality rates. Why? I think we know why, but it's very interesting to see the evidence coming out now to show that high-volume surgery probably is safer. It's been the suspicion for a long time, and the proof is now coming. That surgical care everywhere is getting better. The quality of the care, and again, John Birkmeyer presented some very interesting stuff on the effect of surgical technical skill doing anonymized peer review of an operation. And it was fascinating to see just how much that correlated with complication rates, not least death. We are better at preventing complications, but probably most importantly, at recognizing and rescuing the patient with complications. That's probably the single area that has made the improvement. SASM, over the years, has had a number of successes, and that's some of them listed there. High dependency care provision was an area that it championed for many years with success. And the introduction of early warning scores, the SUSE charts across the country, so that when the juniors move around, they're not having to learn a new system altogether. And those have been just a number of the successes over a good number of years. However, ACONs, the areas of concern that SASM reviews throws up, were still present in 2009, 25% of deaths. And those were the sort of areas, monitoring and assessment post-operatively, pre-op assessment, and so on. I mean, the ways that you would have expected, not least the bottom one, operation not or should not have been done or was unnecessary. Infection. And as you'll have heard recently, we've invented a new strain of C. diff north of the border. Still don't know which hospitals it is. Adverse events in routine care, and then there, mortality is just the tip of the iceberg. You know, it's such a small number compared to the morbidity that we're talking about, and particularly in our elderly population with their multiple comorbidities. The perioperative care needs better examination. We need to be mindful of the expense, both the expense of doing this, but perhaps the expense of not doing this, because it's shown itself to be value for money time and time again if it makes change, but it's only useful if it effects change. Participation is less than 100%. I'm coming back to that, because it is voluntary. As I've said, it doesn't include deaths if they've gone home. It doesn't include deaths if they've been transferred. And for the orthopedic surgeon who flies them off to the geriatricians at 48 hours, you know, that's not going to be a useful audit. So we need to be capturing them. There is no compunction for findings from the audit, from the feedback, to be acted upon. And that, closing the loop, is another failing that has to be addressed and rectified. Difficulties in extracting data from clinical records. Feedback issues. The system as it was and as it is just not fit for purpose because it is far too slow. And for those that are done and completed, to actually go back with useful messages to the clinicians isn't quick enough or complete enough by any manner of means. And for that, and possibly because of the resource limitations within the audit, we're not achieving nearly as much as we could do with this. We did a survey a couple of years ago, and you know, I mean, it was indicative, I think, of the whole problem that we only got a 14% response rate. And within that, there were myths. SASM captures every death. Well, no, it doesn't. Its methodology at that time was to phone the mortuary attendants in each of the hospitals on a Monday morning and ask if they've got any deaths. 100% of consultants, well, no, it's not. And there were individuals sitting on multiple letters from SASM about multiple deaths, just steadfastly ignoring it and nothing happening about it. The myth that there were fail-safe review mechanisms built in, there were not. And that the lessons learned were aggregated in the way that CORES does, which I think is an extremely useful audit. And that the development of an electronic platform for the collection of this data would be quicker and easier. That was the intention, a web-based portal. But the trouble was, all they did was just do an exact replication of the paper form. And that was a missed opportunity in a big way. Yes, it went on to a secure encrypted server, but that in itself was a problem because it limited the access points where people could input data. And, you know, it's been going in that form for 2 years, but flagged red on the risk register within NHS Scotland for 18 months of that, with no action. So that was the paper form, and it just duplicated straight on. And there, you know, I mean, that bottom right box is a relatively new box, because that initial thing was one of the biggest problems. People didn't have to hand their username and password. I mean, you don't, particularly, as I've said, when death is now becoming such a rare event. And then we just hammered through the form as it was on paper, really. And the potential benefits were there to see, and indeed the secure transfer of patient data was important, and that was one of the reasons we were forced down that line, was because the Caldicott Guardian within the NHS in Scotland said you cannot have these paper forms and the case notes travelling up and down the country in the Royal Mail. The potential for speeding the whole thing up and getting real-time reporting, which is what we wanted, with shorter turnaround times, online validations and cleaner data. These were all the potential benefits. Potential. And we've kept working on it, and indeed as recently as December with some fairly major changes. Well, they're not major, but they're incremental, and it's evolved with changes, small changes, which altogether have turned a system that didn't work into a system that now works. And it does work. It's still a bit clunky, and you know, it's, as I said at the start, if we were going there, we wouldn't have started from here. A surgeon can start the form off. He doesn't have to wait for a notification from SASM to say that the hospital's been in touch saying a patient under your care died. A surgeon can initiate the form. And they could print out an individualized report. That'll be there in their portfolio for appraisal and for revalidation. They can reject a study that they'd inadvertently accepted before because it wasn't their patient. Our backlog was so horrendous that we just drew a line and said, well, 2011 is null and void. And we could help with getting notes, and I'll come back to that. That freedom of information request asking for notes, well, you know, you'll be lucky, because getting the list, the accurate list of who has died has been a real problem. And the audit itself was run on a shoestring, essentially with one clinical coordinator running it with a data analyst on board. And what we're doing just now is going around the country, re-engaging with clinicians, because there is still an interest and a willingness from the profession to look at this, to see what is the right way of doing it, and really to assess the effect of these recent changes on the electronic platform. We met with the Scottish medical directors in January, and they, as a group, were hugely enthusiastic that it must continue because they think it is important. They promised to give us a liaison person in each hospital so that we can accurately identify the deaths, accurately attribute them to individual clinicians. They're very keen to get real-time feedback, and they're very keen to see it as a routine part of appraisal and revalidation. They've promised to help because, I mean, you know, this is Scottish Audit of Surgical Mortality, so where are the notes? They're in the death file. You ask for notes from the death file, and it's 6 months before they appear, and sometimes at a price, because these repositories of dead case notes are run by private companies, and that's been a real problem. They're keen that we explore links with M&M meetings, and I'll come back to that, and they're keen to see focused reports with clear recommendations. And there's a but, and it's a big but. And as of March, we were sitting with 54% of the deaths that we knew of neither accepted nor rejected by a surgeon. And that's really where we're at the moment. That's the bottom line. Now, 54%. Now, we've looked at it by month, and just to see if it was an effect of a system that wasn't working and is now working, but there's no clear evidence of that. Those were the numbers. And yes, we've been better, you know, and we've had it as low as 40%, but overall, it's 53%. And of course, you know, the more recent ones, you know, the early months of this year are high because they're the recent ones. So what do we do? What's the future? Do we continue? Do we stop? Do we change? Whatever we do, or if it does continue in some form, we've got to demonstrate effectiveness. So, continue. Re-engagement with clinicians is going on, as I say, with some success. And every time there's been a visit, positive response and a jump in acceptance. There is this clinical support. Now, 1 year ago, 83% were neither accepted nor rejected. But now we're down to 50%. So, there's that improvement, so do we keep going? And then, despite those number of ACONs that I highlighted earlier, the actual number of useful ACONs with learning points in them were actually fairly low from what was a major exercise. So are we flogging a dead horse? So do we stop? But the rest of the world is busy trying to form SASMs. And I've got letters from Australia, New Zealand, Ireland, and I don't think, out of the clear message I'm getting from the patients, the public, the profession, and the politicians, is that they will not let this stop. And you can see why. And that was Bristol. And that was more recently. And David Flum, who was here, was absolutely right. Performance surveillance has to be part of the culture. So, and there is this very clear move to include this within the process of appraisal and revalidation. So do we change? And the system has always evolved. It has always evolved. And I think, if we are to change, it needs a fairly major redesign. And there are other national audits out there that we can learn from. The stroke audit is a striking success with an online platform. They were lucky. They looked at what we did, and they learned from our mistakes and just didn't make them. And they've ended up with an audit that is hugely supported by the profession and is proving extremely useful clinically. We've got to streamline, because the whole process as it stands is far too long. Now, we've got 54% neither accepted nor rejected, so that means 46% are accepted. How long is it before those 46 are going to get any useful feedback on what they've submitted? So we've got to think about how we could streamline the process. The robust peer review is seen as a strength of the audit, so we don't want to lose that. Help with the M&M meetings, which are an integral part of every clinician's life, to a greater or lesser degree. And in some of the small surgical specialties, there are problems with the frequency and the rigor of M&M meetings, some of the big specialties. But there are examples around Scotland where it works extremely well. The general surgical one at Edinburgh Royal Infirmary and at Dundee at Ninewells, they work very well. The Aberdeen general surgical one is showing innovative stuff using Datex reporting forms. So there's a chance then to link in with structured M&M meetings, and I think that would be a win-win. And there's a message that's coming back fairly clearly from all over the country that we want to learn from the cases where there's something to be learned from. So perhaps the first question to say is, was this death expected? Were there any untoward issues? Has it been discussed at your M&M? And if you get the right answers from those three, then that's it. You draw a line. That's that. You don't need to go any further with that. Now, there are risks with that. But then any system that we've got at the moment, and most notably appraisal and revalidation, ain't never going to catch the Shipmans of this world. It's rigorous inspection of routine data that will do that. And how else do we evolve? Well, I mean, that's really the point of this, because I've said the tip of the iceberg is mortality. And the underlying morbidity is probably where the lessons are. And we don't, one of the clearest things is that this audit mustn't exist in its own little silo. It has to link with all the other work that is going on elsewhere. And what we want to do is, whilst it may have this continuing monitoring role that will engage all the surgeons and anaesthetists and intensivists around the country, there's potential for parallel work with focused sprint audits, and we know the areas where to look. An emergency laparotomy in the elderly patient is an obvious one, but come to that. Ruptured aortic aneurysm, and Wesley Stewart's here, and Wesley's leading work in Scotland that has got a huge potential for looking at the vascular side of audit, surgical audit. Hip fracture has been a success over many years, and whilst we've stopped doing it recently in Scotland, the National Hip Fracture Database south of the border is a fantastic success and has demonstrated change. A 15% reduction in 30-day mortality simply from following the protocols and documenting it there. And we would probably revisit hip fracture, and we may, come at it out of left field and look at things like quality of death, because there are large numbers that die and will die with a hip fracture, and it's an end-of-life thing. But the quality of death, and we'll all have had relatives on orthopedic trauma wards who have died after a hip fracture, and, there are lessons there, clear lessons that need to be learned. So the emergency laparotomy, because we know that there's a large body of, it's not the right word, of work. And from Norman's College, that excellent report, and it really was very good on the higher risk general surgical patient. And there is the National Emergency Laparotomy Network doing good work, and Ian Anderson from Salford is leading excellent stuff. North of the border, we've got the Scottish Emergency Laparotomy Improvement Group that is getting going just now, using these links, these natural collaborations with Health Improvement Scotland, with the surgical profiles data that's published every other year. And that's growing arms and legs at the moment. So no silos, work with other bodies. Use these focused sprint audits in areas where we know there are lessons to be learned. And a lot of that identification of those patients is easily done centrally because we've got central data that tells us about emergency readmission, unexpected return to theatre, unplanned ICU admission, massive blood transfusion, extended length of stay. That's all there. So we can pick up those near misses without great effort. And then again, because we're dealing with small numbers, look at the ones that have done unexpectedly well, because there are lessons to be had from there. Whatever we do, if we are continuing in some form, we must demonstrate effectiveness. But then you come down to what is the metric of success? As I've said, if you're measuring something, it's got to be for a reason. And just simply collecting data that goes into a file is no use. One metric may be just the simple evidence of reflection by a clinician on the ultimate complication of care of one of their patients. And indeed, not to do that, to my mind, is surely a mark of disrespect to the patient. If you've looked after a patient and they've died, then, taking time to sit back and think about it has got to be an important part of everybody's practice. And there's a statement, and look at the year it was made, in the 1700s by David Skene, who was a great doctor in Aberdeen. And it doesn't come naturally, And I stand here, an orthopedic surgeon, and you talk to your average orthopedic surgeon about reflective practice, and it doesn't always go down as well as you'd like. But there is a clear role within clinical governance. There is a role for this. And to lose it, I think, would be to the detriment of surgery. John Birkmeyer finished his talks at the Edinburgh College last week saying, if you're going to get this clinical governance, if you're going to get this collaborative quality improvement, you need robust externally audited clinical registry. I mean, that robust peer review is an important part of reassurance to everyone, to the profession, but also to the patients and the public, the politicians. But it's got to be rigorous. It's got to be timely. Anything coming back 6 months, a year down the line, that's not useful. And we must find a way of learning the lessons, disseminating the lessons. And it's a real failure that if we don't do that. So the plan is that we sit down in the summer and we take stock and see what 6 months of this new ESASM and the changes that we've made, what difference does that make to us? Is it working? And if it's not working as well as it should be, I mean, 50%, well, 50% not accepting, but 50% accepting. So, you know, there is evidence, and you take Caress, for instance, which is an entirely serendipitous acquisition of untoward events. And you know the definition of serendipity? When you're looking for a needle in the haystack and you find the farmer's daughter. But never mind. Anyway, Caress, I think, is extremely useful because it takes 3 or 4 or more events of a similar nature and says, well, what are the lessons from this? But that's, again, that's just the very small numbers. But we must use it. The ESASM, it does now work. It's still clunky, but I'm encouraged, going around the country, encouraging surgeons to use it. But I repeat, mortality is only the tip of the iceberg in terms of the lessons that we can learn. Those are the contact details, and I'm happy to share that with anybody afterwards. But you'll look at this. The whole shooting match is based just down the river. Just down the river where the whole thing started, where he was born. I think he would have approved of this. I know that he did when it existed in its previous form. And I'm very honored to have stood here to give this talk in his memory. Thank you very much.